Welcome back to the Culture of Healthcare Quality Measurement and Improvement. This is part three of our series. As you know, this component, the culture of healthcare, is designed to help us understand what it means to work in healthcare settings for clinical engineers. In part one, we focused on the foundations of quality, what it is, how it's defined, and the framework for measuring it. In part two, we explored the programs and measures used in health plans, outpatient care, inpatient care, and under the Meaningful Use program. Now, in part three, we turn our attention to the next step, quality improvement. We've learned how to define and measure quality. Now we'll dig into how organizations and professionals take those measurements and use them to actually make care better. And for clinical engineers, this part highlights where their work really shines because improvement is not just about policies and clinical decisions, but also about the systems and technologies that enable safe, effective, and reliable care. So let's get started. Quality measurement and improvement objectives. So here we will be focused on the last two objectives, which are number three, discuss quality. I'm sorry, not number three. Number four, describe the role of information technology in measuring and improving healthcare quality. So, information technology, again, is the backbone of modern quality improvement, and clinical engineers are key enablers. They ensure devices are connected securely to hospital networks. They validate data accuracy flowing from devices into EHRs and analytic systems. They troubleshoot interoperability issues so that quality dashboards and clinical decision support tools reflect reliable information. And objective number five, describe the results of current healthcare quality efforts in the United States. So, national efforts such as pay for performance programs, public reporting of quality metrics, and the safety initiatives have shown measurable improvements in patient outcomes. From a clinical engineering lens, this results would include things like reduction in device related safety events through better maintenance and monitoring, improved reliability of critical systems like ventilators and infusion pumps during crisis. Just think back to the COVID-19 um, epidemic, pandemic, and also looking at expanded adoption of health IT tools that rely on accurate device integration. IT and informatics in quality improvement. So, in this lecture, we're going to look at the role of information technology and informatics in quality measurement and improvement. And then we'll take a look at some of the results we're seeing from current approaches. So, let's start with IT and informatics. The truth is simple quality improvement can't happen without quality measurement, and measurement can't happen reliably without electronic information systems to capture the data. Think about it hospitals generate enormous amounts of information every day diagnoses, lab results, prescriptions, imaging studies, device outputs, all of it has to be recorded, stored, and made usable. Without IT, there's no way to organize that data at scale. Now, of course, quality improvement goes beyond just the technology. It requires people, processes, and culture. But informatics, the science of using data to guide care, gives us the tools to translate raw numbers into actionable insights. For example, Fowles recently published a series of case studies showing how informatics was used in real world settings to drive improvements, making quality measures something practical, not just theoretical. Standards were also emerging to make this data more usable across systems. And one example is the Quality Reporting Document Architecture, or the QRDA, which provides a common format for quality reports. More recently, we have the Hospital Quality Measures format, or the HQMF. You'll also hear these referred to as e-measures. And the idea behind HQMF is to retool existing quality measures so that they can be extracted directly from electronic health records. Right now, 113 measures have been adapted this way, and the benefit? Well, they're easier to capture, easier to standardize, and easier to report consistently across different hospitals and systems. Now, for clinical engineers, this is where their role intersects directly with informatics. Devices and systems must feed accurate data into EHRs for measures like HQMF to work. So, if a blood pressure monitor, infusion pump, or a lab analyzer doesn't integrate properly, the data may never show up in the quality report, even if the care was delivered correctly. That's why engineers ensure interoperability, they validate data pathways, and troubleshoot the flow of information between devices and records. So the bottom line is this: IT and informatics don't replace quality improvement, but they make it possible. They provide the infrastructure to measure, monitor, and report on quality in ways that can actually drive better care. Evidence on EHRs and quality. So far, we've been talking about the role of IT and informatics in quality measurement, but here's the key question: does using an electronic health record actually improve quality? The evidence suggests sometimes. Let's start with inpatient settings. One analysis looked at hospitals in the University Health System Consortium, which is a group of academic teaching hospitals. They found that hospitals reaching HIMSS analytics stage 4 or higher, that means full EHR adoption, including computerized physician order entry and clinical decision support, scored higher on quality measures. Since 1994, HIMSS also has also given out the what's called the Nicholas E. Davies Award of Excellence to hospitals and organizations that have shown outstanding achievement in using IT and EHRs to improve outcomes and achieve return on investment. So the Davies Award highlights real world success stories, sharing case studies and lessons on how thoughtful implementation, workflow redesign, best practice adherence, and even patient engagement can lead to measurable improvements. Now, another benchmark comes from Hospitals and Health Networks magazine, which sponsors the annual Most Wired survey. So, this has become an industry standard for measuring IT adoption across U.S. hospitals and health systems. The results are published each year in the Most Wired report, which identifies the hospitals considered most advanced in technology adoption. And here again, the findings show that most wired hospitals tend to score higher on certain quality measures. But here's the flip side. In outpatient settings, the picture is less clear. Some studies have shown that just having an EHR in place doesn't necessarily lead to better outcomes in areas like diabetes management or general ambulatory care. So, in other words, the technology alone isn't enough. And as Dr. Richard Barron puts it, better quality is not automatic. It requires substantial effort, workflow redesign, staff training, consistent measurement, and active engagement with the system. So simply installing an EHR doesn't guarantee better care. Now, for clinical engineers, this distinction is crucial. In hospitals, EHRs paired with strong IT support and clinical decision tools can clearly enhance quality, but only when the systems are integrated properly, devices feed accurate data, and workflows are optimized. In outpatient care, engineers may need to help providers go beyond just adopting the technology to actively aligning it with quality improvement goals. And so the takeaway is EHRs and IT can enable better quality, but only if the people, processes, and technologies around them are aligned. And to go off on a third level removed from this main topic, clinical engineers wanting to improve their integration into the health system, well, they also need to um, adopt and align themselves better with the uh, primary care and primary and secondary care systems of healthcare. Public resources for case studies and best practices. One of the best ways to learn about quality improvement is to see how others have done it. And the good news is there are many publicly available resources that share case studies, best practices, and real world examples of how healthcare organizations have improved quality and safety. These resources don't just describe problems, they highlight the solutions that worked, and they often include step by step strategies for how hospitals, clinics, and health systems made measurable improvements. So, on this slide, you'll see a sampling of industry organizations that publish these kinds of resources. They provide case studies, toolkits, and best practice guides that show how providers have successfully leveraged quality initiatives to improve care, delivery, outcomes, and patient safety. For clinical engineers, these case studies can be incredibly valuable. They often touch on topics like technology adoption, workflow integration, device reliability, and IT systems, all areas where engineers play a critical role. So, by studying what worked in other organizations, engineers can anticipate challenges, adopt proven solutions, and contribute more directly to quality improvement efforts in their own institutions. So, the key takeaway here is you don't have to reinvent the wheel. Many organizations have already tested and shared what works. So, by tapping into these publicly available resources, both clinicians and engineers can build on those successes and avoid repeating the same mistakes. Resources and assets for quality activities. When it comes to carrying out effective quality initiatives, providers rely on a whole ecosystem of resources: information technology, organizational leadership, and staffing. The role of IT can't be overstated. The number of complexity of systems a provider uses depends on their size and scope. So a small outpatient clinic may only have a basic EHR and billing system, while a large academic medical center could be running dozens of interconnected platforms. So where does the data for quality measures come from? It's pulled from source systems like clinical information systems, electronic health records, radiology, and lab systems. Physical therapy and rehab systems also are included. Other things could be patient care plans and decision support tools. Even financial and billing systems feed into quality measurements. Larger organizations often add a data warehouse or a repository to pull all this information together and then use analytics and, and reporting tools to make sense of it. But technology alone isn't enough. Leadership and executive support are critical. Successful quality programs have champions like the chief of medical staff, the chief nursing informatics officer, and the chief medical informatics officer driving that effort. But also, they also set the tone for data governance. The policies and procedures that ensure data is accurate, consistent, shareable, and compliant with regulations. So, in simple terms, data governance treats data like an enterprise asset, something to be managed with as much care as financial or physical resources. And quality isn't just the job of leadership, all staff are involved. So, a quality study might require input from finance, operations, patient satisfaction surveys, or marketing, in addition to clinical data. IT staff support the underlying applications and reporting tools. Large organizations, excuse me, often employ dedicated clinical informatics teams whose entire job is connecting technology, workflows, and quality initiatives. Education is also essential, and it's not a one and done event. Ongoing training keeps staff aligned with the organization's quality program, ensures everyone understands their role, and adapts as measures evolve. It's worth remembering that not so long ago, all of this was done on paper. But today's complexity, multiple initiatives, overlapping measures, massive data sets can only be managed through integrated technology supported by skilled technical and informatics staff. Now, for clinical engineers, this ecosystem highlights why their role matters. They ensure that the devices feeding into these systems are reliable, that they're calibrated and interoperable. If a lab analyzer or an imaging system doesn't transmit data correctly, the downstream analytics won't reflect reality. In that sense, engineers are the guardians of data quality at the very source. And the takeaway is that quality initiatives succeed when IT, leadership, staff, and engineering all work together. Technology provides the foundation, leadership provides the direction, and staff across every role make it real. They make it happen. Industry initiatives in health IT. When we think about advancing healthcare quality, it's not just hospitals and providers pushing forward. There are also industry wide initiatives that support the growth of health IT and information systems. Let's start with the Health IT certification program. And this program runs in parallel with the High Tech Meaningful Use initiative. Its purpose is to certify health IT systems and standards, making sure that the software providers use actually meets the technical requirements for each stage of meaningful use. And every time the regulations are updated, the certification criteria get updated too. And why does this matter? Because certification has pushed forward the use of data standards and systems functionality. That makes it easier to collect accurate data, analyze it for quality reporting, and just as importantly, use it to improve patient care. It's also promoting greater patient and family engagement and smoother information exchange across the care continuum. And then another key player is the HL7 or the Health Level 7 International, which is HL7 is a standards development organization. Their job is to create, revise, maintain standards that allow healthcare data to flow. So HL7 standards show up everywhere in EHRs, billing systems, lab systems, and imaging systems. They've even worked with the National Quality Forum and the Office of the National Coordinator for Health IT to align EHR use with quality measured standards. Then there's IHE, which is the integrating the healthcare enterprise. So IHE provides frameworks and technical profiles that help organizations actually implement quality data collection and exchange. And so their work touches on areas like clinical research, drug safety, early hearing loss detection, newborn screening, and structured data capture. And so these tools often form the backbone of modern clinical information systems. Then we have the Commonwealth Health Alliance. And this is another initiative worth noting. It's vendor led, which means technology companies are at the table working together to make health IT systems interoperable across the country. And their focus is on patient identity management, secure data exchange, and linking records across multiple organizations. The idea is to break down silos so that a patient's information follows them no matter where they go for care. And of course, these are just a few examples. There are many other initiatives out there, each contributing to the development, implementation, and promotion of IT systems that support clinical practice. They improve outcomes and enhance patient safety. So, for clinical engineers, these initiatives may feel like big picture industry work, but they have direct impact at the bedside. Certified systems mean the devices you maintain can connect reliably to EHRs. Standards like HL7 make it possible for lab imaging and monitoring systems to talk to one another. Alliances like Commonwealth help ensure that the data your devices generate doesn't get lost when a patient moves from one hospital to another. And the message here is clear. Industry initiatives set the stage for how technology works in practice, and engineers make sure it works in reality. Demonstrating the value of health IT. Alongside regulations and standards, there are also industry efforts designed to show what effective use of health IT really looks like and to give providers resources they can use to support their own technology journey. One example is the HIMSS Nicholas E. Davis Award of Excellence. This award recognizes outstanding use of health IT, specifically EHRs, by organizations, private practice, and public health systems. The award also is modeled after the Baldrige Award and asks applicants to evaluate themselves in four key areas: so management, functionality, technology, and overall value. In fact, the application itself often serves as a kind of assessment tool, helping organizations plan or refine their EHR implementation. Winners are recognized in categories like hospitals, ambulatory practices, and public health. And importantly, all the winning case studies are available on the HIMSS website for anyone to learn from. Another benchmark you've probably heard of is the HIMSS EMR adoption model, or the MRAM. And since 2005, HIMSS Analytics has tracked how hospitals adopt EMR technologies, expanding to clinics in 2012. And the model defines 8 stages from 0 through 7, with stage 7 representing a fully digital environment where paper charts are eliminated. Reaching stage 7 is a major milestone, and HIMSS publishes a list of organizations that make it there. They also share case studies from stage 7 hospitals showing how superior use of IT systems translated into better processes, higher quality care, and improved patient safety. So HIMSS hasn't stopped there. They've also released the continuity of care, the maturity model, which goes beyond MRAM stage 7. This model focuses on big picture goals like interoperability, care coordination, patient engagement, analytics, and ultimately managing both individual and population health in a more holistic way. Another valuable resource is the HIMSS Health IT Value Suite. So this collection highlights hundreds of real-world examples where hospitals, physician practices, communities, and accountable care organizations have realized measurable value from IT. These aren't just success stories. They include detailed strategies, tactics, and metrics so their organizations can replicate that work. Beyond HIMSS, there's also industry-wide resources and conferences that help providers navigate the crowded IT landscape. One example is CLOS Research, which provides vendor and product reviews, market research, and reports. So providers can use CLOS to compare EHRs, quality reporting tools, decision support systems, and other IT products before deciding what best fits their organization. So what's the takeaway here? Providers don't have to figure this out on their own. There are rich libraries of case studies, benchmarks, and evaluations that show how IT can and has improved quality, safety, and outcomes. So, for clinical engineers, these resources are a roadmap. They show how successful organizations used not just software, but also devices, integration, and infrastructure to achieve results. Engineers can study these examples to anticipate challenges, align their technology work with quality goals, and push their organizations toward higher levels of IT maturity. EHR data and quality measures. So, whether or not electronic health records always lead directly to better care, one thing is clear: EHRs are essential for quality measurement. At this point, it's really a requirement. There's tremendous value in the coded information an EHR contains. For example, one analysis by Tang and colleagues showed that EHR significantly improved the ability to assess diabetes quality measures. On the flip side, using only administrative or claims data isn't enough. If you want to calculate HEDIS measures, the health plan employer data and information set, you need the richer clinical data that EHRs provide. So EHR data can improve accuracy for calculating HEDIS measures and metrics like disease-specific mortality. But here's the catch. Just having an EHR doesn't guarantee that the data inside is usable for quality reporting. A lot of what gets documented is narrative text, clinical notes that aren't easy to extract or analyze. So take heart failure as an example. Sometimes the data you need, like why a patient isn't prescribed a beta blocker or an ACE inhibitor, is buried in the notes. That information is critical for quality measurement, but it's inaccessible in coded fields. There is some good news though. Natural language processing, or NLP, is starting to fill in this gap. In some areas, NLP can pull data from narrative text as effectively as a human reviewer. It's not perfect and can't yet be applied universally, but in specific domains like smoking cessation advice, diabetic foot exams, or congestive heart failure management, it can work. And it can work remarkably well. So in reality, most EHRs are a mix of discrete coded data and free text. That means organizations often rely on system applications for data mining, pulling out useful pieces of information for reporting. And these systems aren't flawless. They still require human oversight, but they provide another valuable tool for supporting quality reporting. So for clinical engineers, this is an important reminder. The quality of reporting depends not just on what clinicians document, but on the systems that capture and process the data. Devices must feed accurate coded data into the EHRs. Interfaces must handle both structured data and text, and engineers often support the technical backbone that makes the NLP or the data mining applications possible. And the big picture is that EHRs expand what's possible in quality measurement, but only when the data inside is accessible, it's accurate, and it's usable. Results of currently quality measurement approaches. So now that we've looked at the different types of quality measures, the programs that use them, and the role of IT and EHRs in capturing data, let's step back and ask the big question, do these measures actually work? So in other words, does better performance on quality measures, especially processes measures, really lead to better patient outcomes? The research here is mixed. There's evidence for the idea that following process measures improves outcomes in certain conditions. For example, in areas like acute heart attack care, sticking closely to the recommended steps has been linked with improved survival rates. But there's also evidence against it. In some situations, scoring well on process measures doesn't always translate into better outcomes. So that might be because outcomes are influenced by many other factors, patient comorbidities, social determinants of health, or even random variation. And beyond that, other problems can arise from our current strategies for measuring quality. And sometimes the measures are too rigid, capturing whether a box was checked, but not whether the care was meaningful. And sometimes the reporting burden itself can take time and resources away from patient care. So for clinical engineers, this tension is familiar. Just because a system reports that a device passed its preventive maintenance process doesn't always guarantee the outcome will be safe performance in a critical moment. Process is important, but it's not the whole story. In this section, we'll look more closely at what the research says about current approaches where process measures connect well to outcomes and where they don't, and what challenges exist as we try to improve quality measures. Pay for performance and ACOs. So, one of the big trends in US healthcare today is the shift away from the traditional fee for service model where providers are paid the same regardless of patient outcomes and toward a pay for performance or P4P model. In pay for performance, provider payment is linked to the quality of care and the outcomes that patients experience. And one US example is the Accountable Care Organization, or the ACO. ACOs bring together different providers across a continuum of care and hold them collectively accountable. Do process measures improve outcomes? So here's a big question. Does better performance on process measures actually lead to better patient outcomes? And the answer is yes and no. On one hand, there's strong evidence that it can. For example, patients who choose a top performing hospital or surgeon, those in the top quartile experience about half the mortality rate compared to those treated at the lowest performing quartile. If every patient had access to those top performers, mortality would likely be much lower across the board. Of course, there's the Javon's paradox there, where the more people who would use those same top performers would cause fatigue in those same top performers, bringing back the mortality rate to be average from what it was when it was everyone involved. So it doesn't. There's a paradox there, which I won't get into. Anyway, that's enough. That's kind of all you need to know about it. So we also see this in national initiatives. Hospitals that participated in the Hospital Quality Alliance that showed lower mortality rates for conditions like myocardial infarction, pneumonia, and congestive heart failure. And that tells us that aligning with standardized measures and accountability structures really does move the needle on outcomes. So another example comes from the Leapfrog Group, a coalition that promotes patient safety and quality standards. So hospitals that adopted leapfrog practices demonstrated better quality and lower mortality for acute heart attacks. So yes, when process measures are carefully chosen, supported by evidence, and consistently applied, they can and do improve patient outcomes. But the no part comes in when process measures become checklists that don't capture the full complexity of patient care. And not every process measure has a tight correlation with outcomes. And sometimes performance reporting can drift into box checking without real clinical impact. So, for clinical engineers, the lesson here is clear: process measures only improve outcomes when the underlying systems and technologies are reliable. If a hospital is measured on timely antibiotic delivery for pneumonia, the pharmacy, the EHR, and the infusion pump systems all have to work seamlessly. If the measure is about surgical infection prevention, sterilization equipment and OR monitoring systems need to be flawless. So the takeaway is better processes can lead to better outcomes, but only when they're tied to evidence, consistently implemented, and supported by reliable technology. When process measures don't translate to outcomes. Unfortunately, the story doesn't end with the good news. Not all research supports the idea that better performance on process measures always leads to better outcomes. For example, one study found that across various process measures, hospitals could predict only small differences in mortality for myocardial infarction, congestive heart failure, and pneumonia. In other words, even when hospitals scored well on processes, it didn't necessarily mean their patients were more likely to survive. Another study looked specifically at CHF quality measures developed by the American College of Cardiology and the American Heart Association, and the surprising result was that those measures had little relationship to mortality or rehospitalization rates. And perhaps one of the most discouraging findings came from a pay for performance initiative. Hospitals that participated in this quality effort didn't actually improve on the process measures. And as you might guess, their patients didn't have better outcomes either. There are other examples too. A smoking cessation metric didn't correlate with whether patients actually quit smoking. A door to balloon time measure for heart attack patients that it didn't line up with other quality indicators or with mortality. And the use of CMS heart failure measures has not been associated with improved outcomes either. So, what does this tell us? Process measures can be valuable, but only when they truly reflect actions that drive better outcomes. Otherwise, they risk becoming checkboxes that consume time and resources without making a real difference for patients. So, for clinical engineers, there's a lesson here as well. Just checking the box that preventive maintenance was done on a ventilator doesn't guarantee the device will perform flawlessly in a crisis. What matters is whether the work being measured has a direct impact on safety and reliability. Measures that don't tie tightly to outcomes may not deliver the improvements we hope for. And so, the big picture, process measures aren't the enemy, but they're not a guarantee. They need to be carefully chosen, evidence based, and always evaluated against the outcomes that really matter: patient safety, recovery, and the quality of life. So, again, just to reiterate that, again, preventive maintenance that was done on a ventilator, like I said, doesn't guarantee the device will perform flawlessly in the crisis because it's not just so much that it works or what works. You also have to look at what resonates with clinicians in time of crisis. Public reporting and quality. So, does public reporting making performance scores for doctors and hospitals available to the public actually improve quality? The evidence here, again, is mixed and in many cases not very encouraging. The recent systematic review found very little evidence that simply publishing performance data led to improved quality of care. Patients could see the numbers, hospitals could see how they stacked up, but the data alone didn't translate into big improvements. That said, one study found that public reporting combined with pay for performance worked better. When transparency was tied to financial incentives, providers improved more than with public reporting alone. Another interesting perspective comes from physicians themselves. A study of general internists in the United States showed that many doctors actually supported financial incentives for quality, but they were wary of public reporting, and they're concerned that publishing raw performance data might discourage doctors from taking on sicker or more complex patients because those cases could make their numbers look worse, even if they were delivering excellent care. And we see similar findings outside the US. Um, in Canada, public report cards didn't lead to improvement in outcomes for myocardial infarction or congestive heart failure. And on top of that, patients often struggle to understand the report cards in the first place. The suggestion was that a clearer framework using plain language would be more effective than complicated technical scorecards. So, what's the takeaway? Public reporting alone isn't a silver bullet. It may push some accountability, but unless it's paired with incentives, support, and clear communication, its impact is limited. So for clinical engineers, there's a parallel lesson here. Publishing equipment uptime reports or safety metrics internally doesn't automatically lead to improvements. If the data isn't actionable, if it isn't communicated clearly, or if it creates perverse incentives, like avoiding the toughest repairs or systems, it may not drive better outcomes. Just like in clinical care, transparency has to be paired with incentives, education, and a supportive framework to truly make a difference. Problems from current approaches. So, up to this point, we've been talking about how quality is measured, the different programs that support it, and the role of IT and informatics. But we also need to pause and take a critical look at the problems that come with our current approaches. On this slide, you'll see three broad areas where challenges merge, um, or where they arise, where they emerge. So we have measurement issues. And sometimes the measures we use don't truly reflect meaningful outcomes. They may be too narrow, too rigid, or simply not aligned with the real complexities of patient care. And in some cases, they even create incentives for box checking instead of focusing on what matters most for patients. Challenges for certain practice environments. So, not every healthcare setting has the same resources. A small rural clinic doesn't have the same IT infrastructure as a large academic medical center, and this creates uneven ability to collect, report, and act on quality measures, leaving some providers at a disadvantage. There's also ethical issues. So, quality measurement can raise tough ethical questions. For example, public reporting might discourage providers from taking on sicker or more complex patients for fear of looking like poor performers, or pay for performance incentives might unintentionally widen gaps in care between different populations. So, for clinical engineers, these issues matter just as much. If the quality measures tied to technology are too simplistic, they might miss critical safety risks. Smaller organizations may struggle to keep devices interoperable with the EHRs, making it harder to report accurately. And engineers themselves face ethical decisions like balancing patient safety with cost constraints or ensuring fair access to safe and effective technology across all patient groups. So, as we move forward, it's important to remember that measurement and improvement are powerful tools, yes, but they come with limitations and responsibilities that we have to address, like anything else. Challenges in quality measurement. So let's talk about some of the challenges we face in measuring quality. Because while the idea of just measure and improve sounds straightforward, the reality is a lot more complicated. One big issue is with elderly patients. Many older adults have complex comorbidities. That means multiple diseases happening at once. And in those cases, the one size fits all guidelines that get baked into performance measures may not be appropriate. So, the UK, for example, their pay for performance system actually allows exclusions when a guideline doesn't fit. And while there are concerns this might lead to gaming the system where doctors exclude patients just to look better, studies found that wasn't happening in practice. Another challenge is that care is often fragmented. A Medicare patient might see a primary care physician in one system, a cardiologist in another, and perhaps a specialist affiliated with a different hospital altogether. So, how do you attribute quality? Is it fair to credit or blame just one provider when multiple practitioners are involved? Measures also risk becoming obsolete. For example, when new clinical trials change recommendations for managing cholesterol or diabetes, existing quality measures may suddenly be out of date, no longer reflecting the best science. And then there are unintended consequences. Robert Wachter, he's a well known quality expert who shared a concerning but almost comical example from his own hospital at UCSF. So, patients with congestive heart failure sometimes ended up being treated with antibiotics that they didn't need. And why? Because when a sick patient came in, pneumonia was the first thing doctors had to rule out. To make sure they didn't miss the pneumonia quality measure, some physicians prescribed antibiotics just in case. Later, it turned out that the patient had CHF, not pneumonia, so they got unnecessary antibiotics, all in the name of hitting a metric. And another complication is the multiplicity of measures. So, with many measures in place, they sometimes conflict. For instance, in stroke care, certain measures designed for general patients may not be appropriate for all stroke patients. And this creates confusion and even conflicting directives. And finally, there's the problem of sample size. Most physicians don't actually see enough patients in specific categories to produce statistically reliable differences in performance, and that makes it hard to draw fair comparisons. There's an individual, Don Berwick, one of the leading voices in healthcare quality. He argued that instead of focusing on narrow, fragmented measures tied to one payer or program, we need to think broader, multiple measures across all payers to get a more complete and fair picture. So, for clinical engineers, these challenges echo in their own world. Devices may be evaluated against rigid benchmarks that don't always fit every clinical scenario. Fragmented IT systems can make it hard to trace data across care settings, and sometimes performance metrics may encourage shortcuts like over testing or over alerting rather than focusing on meaningful outcomes. And so the takeaway is that measuring quality is essential, but it's also very messy. We need to recognize the limitations of current measures and work towards systems that reflect the complexity of real world care. Challenges for different practice environments. So, another layer of complexity in quality measurement is that not all healthcare environments are the same, and that creates challenges. For example, some measures can look very different depending on the size of the hospital. In smaller hospitals, the small number of patients can actually inflate performance results compared to larger hospitals. And that means measures often need to be adjusted for different settings, or they risk giving a misleading picture of quality. Then there are safety net hospitals. These are institutions designed to serve patients who don't have other options. People without insurance, people with limited means, people who rely on the hospital as their last resort. But safety net hospitals often struggle with funding and staffing shortages. If you tie their reimbursements directly to pay for performance, you may end up punishing them for circumstances they can't fully control. Worse, it could worsen disparities in care by taking resources away from the very institutions built to close those gaps. So, small medical practices also face their own unique challenges. Many have limited staff, limited capital, limited time. They may deal with multiple payers, each with their own requirements and only small margins to invest in technology. One physician in Massachusetts put it bluntly, and he said, is it becoming overly burdensome for small practices to be overwhelmed by all of these different quality measures and the computerization of their practices? So, for clinical engineers, this highlights the importance of context. A large academic medical center may have full informatic teams and data warehouses, while a rural or safety net hospital may have only the basics and maybe one or two engineers to handle it all. Technology solutions and quality measures need to be scalable and fair across these environments, or else they risk widening the gap between well resourced and under resourced institutions. So the challenge isn't just designing good measures, it's making sure those measures work fairly across all practice settings from the smallest clinic to the largest health system. Ethical issues in quality measurement. Finally, let's touch on some of the ethical issues that come up in quality measurement and improvement. And these are complex questions, and what I'm sharing here is just a brief overview. For those of you who want to go deeper, I strongly recommend looking at the papers listed on this slide. And one issue concerns patient consent. When someone joins a research project, protections are in place. An institutional review board reviews the study to ensure it's ethical. But what about quality interventions? If you're testing a new quality measure, is that part of patient care or is it research? This came to light when a project wasn't vetted by a review board at all. Lynn Snyder and Miller argue that quality interventions should be considered part of the normal care, but it's a debate worth noting. Another ethical issue is about who pays for the preventable complications. Everyone agrees that if a surgical sponge is left inside a patient, that's preventable and the hospital should be accountable. But what about a patient who develops pneumonia while on a ventilator? Was it truly preventable or was it an unavoidable risk? So deciding which complications are truly preventable isn't always clear, and That makes financial responsibility murky. So the Affordable Care Act hospital readmission reduction program raised similar concerns. CMS began reducing payments to hospitals with excess readmissions within 30 days. But again, are all readmissions preventable or are some simply unavoidable given patient complexity? And then there are tensions between different stakeholders. Patients often want everything focused on their care. Purchasers, like employers or insurers, are often focused on cost, and physicians may feel caught between their internal motivation to care for patients and the financial incentives of pay for performance programs. Thankfully, one study found that doctors' internal motivations weren't harmed by P4P, but the tension is still there. And for clinical engineers, ethical challenges also arise. Should patients bear costs when devices malfunction? How should hospitals handle accountability when poor integration of technology leads to errors? And how do engineers balance cost pressures with the ethical obligation to ensure the safest, most effective devices are available? The big, the big picture is this: quality improvement isn't just technical, it's ethical. And navigating these issues requires careful thought, fairness, and transparency. Toward a high performance healthcare system. So, after everything we've covered about measurement, improvement, and the challenges along the way, the big question is, how do we actually achieve a high performance healthcare system? The Institute of Medicine, the Office of National Coordinator for Health IT, and others have emphasized the need for what they call a learning health system. This is a system that doesn't just deliver care, but also learns from every encounter, every patient, every data set, so it continuously improves. And to do that, it needs a strong infrastructure, including informatics and IT. So to capture what works and feed it back into practice. And the Commonwealth Fund has been tracking the nation's quality problems and offers a vision for high performance care. And their report stresses a few guiding principles. And one of them is all patients should have access, not just to care itself, but also to information. And just as importantly, patients need to be accountable for using that information to make informed, appropriate decisions. Also, providers must coordinate care across the entire continuum: primary care, specialty care, hospitals, rehab, even home care. No more silos. And perhaps most importantly, providers and organizations need to embrace continuous learning and improvement, always measuring, always adjusting, always striving to do better. Some experts argue that we should focus less on quality as a technical checklist and more on the value of care and the outcomes achieved are relative to the resources invested. Value will combine both quality and efficiency that aims to deliver the best possible results at some sustainable cost. And for clinical engineers, the learning health system is both a challenge and an opportunity. Devices, IT systems, and data flows are central to learning. So if the systems aren't reliable, interoperable, and producing trustworthy data, the cycle of continuous improvement breaks down. But when they're managed well, engineers help power the feedback loops that let healthcare systems learn from within themselves. And the ultimate vision is a system where patients are informed and engaged, and providers are coordinated and accountable, and technology enables continuous learning. That's what high performance looks like. And it's where the healthcare system is trying to go. CMS 2016 Quality Strategy. So, to close this discussion, let's take a look at how the Centers for Medicare and Medicaid Services, or CMS, updated its quality strategy in 2016. And this update, released in late 2015, it made it clear where the U.S. healthcare system was headed. The central goal was to shift Medicare payments from volume to value. In other words, moving away from paying for how much care is delivered and instead rewarding the value of that care. The targets were pretty ambitious. By the end of 2016, tie 30% of traditional Medicare payments to alternative payment models, tie 85% of all traditional Medicare payments to quality or value. The vision here is to drive a healthcare system that delivers better care, smarter spending, and healthier communities. And that means healthcare providers need to be at the top of their game to support this strategy. CMS also laid out 6 specific goals aligned with the national quality strategies. And the first goal was to make care safer by reducing harm caused in the delivery of care. The second goal was to strengthen person and family engagement as partners in care. Goal 3 was promote effective communication and coordination of care. Goal 4 was to promote effective prevention and treatment of chronic diseases. Goal 5 was to work with communities to promote best practices of healthy living. And Goal 6 was to make care affordable. So, together, these goals form a roadmap for transforming the U.S. healthcare system into one that is safer, more patient centered, more preventive, and more cost effective. And for clinical engineers, this strategy isn't just background policy, it directly affects their work. So, safety depends on devices being reliable and well managed. Patient and family engagement often require user friendly technology at the bedside or in the home. And coordination of care relies on interoperability, making sure devices and systems communicate across settings. So, prevention and chronic disease management increasingly depend on connected devices and remote monitoring. And affordability means engineers must help maximize the value of technology to ensure that every dollar is spent wisely. And the bottom line is that CMS 2016 quality strategy wasn't just about policy, it was about redefining the culture of healthcare to focus on outcomes, safety, and value, and community health. And every role from physicians to engineers is part of making that strategy real. How CMS plans to achieve its goals. So, how exactly does CMS plan to achieve those 6 ambitious quality goals? And their strategy lays out some very concrete steps. First, CMS will measure and publicly report providers' quality performance and the cost of services. Transparency is key, so both patients and providers need to see how care stacks up. Second, they'll provide technical assistance and foster learning networks for quality improvement. And this recognizes that improvement isn't just about measurement, it's also about giving providers the tools and support to actually do better. Third, CMS will adopt evidence based national coverage determinations. That means reimbursement decisions will increasingly follow the science, ensuring that coverage services reflect what works best. And fourth, they'll create incentives for quality and value. And this is a push away from fee for service and toward patient or payment models that reward outcomes. Fifth, or number 5, CMS will set standards for providers that directly support quality improvement. Again, these standards create a baseline of expectations for everyone delivering care. And finally, they'll create survey and certification processes to evaluate whether organizations have the infrastructure and capacity for quality assurance and improvement. So, for clinical engineers, each of these steps has a ripple effect. Public reporting relies on accurate device and system data. Learning networks depend on sharing best practices for technology integration. Evidence based coverage decisions shape what devices and systems get used. Incentives for value highlight the importance of reducing downtime and errors, and standards and certifications often touch on equipment safety, interoperability, and IT security. So, CMS's plan is not just a policy document, it's the blueprint for transforming how quality is measured, supported, and rewarded across the healthcare system. Rewarded and maybe less punitive um, across healthcare systems. As we conclude part 3 of quality measurement and improvement, in this session, we've seen how informatics and information technology play a vital role in measuring healthcare quality. Without reliable systems to capture and process data, quality improvement just simply is not possible. We also looked at the research evidence on current quality efforts. The results are mixed. Sometimes better performance on process measures does translate into better outcomes, but in other cases, the link isn't so clear. Along the way, we explored some of the challenges in quality measurement, particularly for smaller practices, safety net hospitals, and organizations with fewer resources. And we touched on the ethical questions that come with these efforts. How to treat quality interventions in relation to research, who should bear the cost of preventable complications, and how to balance the priorities of patients, providers, and payers. The takeaway is that quality measurements and improvement are essential, but they are also complex. They require careful attention to data, technology, organizational context, and ethics. And for clinical engineers, this means their role is not just technical, it's central. The systems they maintain, the data they ensure, and the safeguards they build are all part of how healthcare measures and improves its quality. Conclusion of quality measurement and improvement. And that brings us to the conclusion of our unit on quality measurement and improvement. And that actually brings us to the end of this entire course on healthcare culture. So, across these last three lectures, we explored the three major types of quality measures: structural, process, and outcome, and how they're used to evaluate healthcare performance. We saw that these measures appear in many different settings: health plans, through HEDIS, outpatient care through PQRS, inpatient care through HQA, and as part of the High Tech Meaningful Use program. We also highlighted the critical role of information technology and informatics. So without EHRs, device integration, and data standards, it would be impossible to capture and report quality consistently or to use that information to drive improvement. Finally, we reviewed the results of current quality efforts in the United States. The record is mixed. There are real successes, but also persistent challenges. Some measures align better with outcomes, while others fall short. And issues like fragmented care, resource disparities, and ethical concerns remind us that quality improvement is not simple. The big picture is this: quality measurement and improvement are ongoing journeys, not final destinations. They require continuous learning, adaptation. They require collaboration across every role in healthcare. That's coming from me, Mr. Collaborator. And again, for clinical engineering in general, the message is pretty clear that clinical engineers' work isn't just about devices, it's about enabling the systems, the data, and the infrastructure that make quality visible and improvement possible. So, with that, we close this unit. And as we move forward, remember that quality in healthcare is not accidental, it is built, it is measured, and it is continuously improved one step, one system, and one patient at a time. I want to thank you for your time and good health.